I'd like to thank the Amyloidosis Foundation for inviting me to talk about emerging treatment landscapes for cardiac amyloidosis. These are my disclosures. I have support from the NIH for some of our research, as well as several pharmaceutical companies who are actively engaged in developing therapies for patients with cardiac amyloid. But my most happy disclosure, I would say, is that there's been a kind of revolution in the field of cardiac amyloidosis with a great understanding of how we can target the production of amyloid and amyloid fibrils, such that there are a host of emerging therapies that will likely, I believe, dramatically improve the quality and quantity of patients with this condition's lives. So as a brief background, there are two main types of cardiac amyloidosis, two main precursor proteins that can deposit in the heart or the myocardium and cause cardiac amyloidosis. And it's essential as a provider and a patient and a loved one of a patient to make sure that you have appropriately been diagnosed with which type of cardiac amyloidosis you suffer from. The reason that this is imperative is because the causes differ not only with regard to the precursor protein, what causes it deposits in the heart, but the biology of the diseases are very different. The natural history and therefore the prognosis for individual patients with different forms of cardiac amyloidosis are quite different. Some forms have a genetic component, so that'll be important for family members to be aware of. And obviously, different forms are treated very differently. As shown in this outstanding slide from colleagues at the Cleveland Clinic, the two most common types are what we call AL amyloid, a disorder of the bone marrow, in which plasma cells produce misfolded light chains that form amyloid fibrils and deposit in the myocardium. And then there's so-called transthyretin amyloidosis that, as we'll see, occurs in one of two forms, either wild type or hereditary, in which a tetrameric protein, meaning a protein that looks like a four-leaf clover, dissociates into pieces, or dimers or monomers. Those form amyloid fibrils, and this principally deposits in the myocardium or in the nerves. I further highlighted here the differences between the various types of cardiac amyloidosis. Again, AL, A always standing for the word amyloid, and the next letter indicating the precursor protein, in this case the light chain, is a disorder in which, again, plasma cells make excess light chains. There's no known definitive genetic cause, and this typically affects people in their 40s to 80s, wide range. And in general, males and females are equally affected. This is a systemic disease. Cardiac involvement is very common, but not universal, typically somewhere in the 60 to 70% range. But being systemic, it also causes manifestations in other organs, particularly in the kidney, something called nephrotic syndrome, which the kidney is damaged and leaks a lot of protein. There can be peripheral and autonomic neuropathies. There can be involvement in the liver and in the skin. The prognosis for patients really depends upon when they're diagnosed. And unfortunately, for patients who are all too often diagnosed very late with advanced heart failure, the prognosis is quite poor without any treatment. I think this is an estimate of what the prognosis is, unfavorable of you. It's actually much better with treatment, even in patients with advanced disease. And the main treatment targeted at present for this condition is something that targets the plasma cells to reduce their production of the light chain. Then there's TTR amyloid. As I said, occurs in two forms, one that's so-called variant or hereditary. That is, that it's inherited in an autosomal dominant fashion. That means that if you're a patient who has hereditary TTR, any first-degree relative, a mother, a father, a sister, a brother, or a child has a 50-50 chance of inheriting the same variant or gene. Just because you inherit the variant doesn't mean you're going to develop the condition, but obviously you're at increased risk if you have the variant as opposed to not. There are over 130 mutations in this protein, and so what we call the epidemiology when people develop disease is highly dependent upon which variant, which mutation, if you will, people inherit or have. It does have somewhat of a male predominance. Cardiac involvement is quite common in patients, and most patients have what I would call a mixed phenotype, in which this protein seems to like the heart and the nerves, and so those are the two main organs affected. Again, prognosis is always dependent upon when someone is diagnosed, whether it be early in the course of the illness or later, but there's a wide range of survival estimates, and those are just that, estimates. Very hard to predict for an individual patient. And in this particular disease of variant, we have two choices of therapy, so-called silencers that stop the production of the protein, and drugs that are called stabilizers. For wild-type disease, which is a disease typically of older adult males over the age of 60, we're not sure why there's such a male predominance, and this could turn out to just be a bias that females might be as affected as males and just underdiagnosed. Again, there's no mutation in this particular TTR protein. That's why it's called a wild type. So there's no genetic inheritance. Family members are not at risk. That's why you need to do TTR genetic testing to distinguish these two. And this disease almost always involves the heart, can involve other ligaments such as the carpal tunnel or the lumbar spine, or other tendons. We've seen an increased risk in such patients of needing hip and knee replacements. And this doesn't seem to cause much of a neuropathy as variant or hereditary disease does. And again, the only approved therapy for this condition presently is stabilizers, particularly a drug called tafamidis. But we'll talk further, there's a rapidly evolving field. So when I see a patient who has a potentially amyloidosis, these are standard 6 blood tests that we get. It's important to assess for what we call monoclonal proteins. These are the proteins produced by the plasma cell that can cause AL amyloid. And we assess that with something called a serum free light chain assay that measures both the kappa and lambda free light chains. We also look for monoclonal proteins in the blood or serum and also in the urine. So these are the assessments that everyone should get for monoclonal proteins. And then there are various blood tests that can be obtained measuring biomarkers. These are blood tests that indicate how the heart is working. One called BNP, or B-type natriuretic peptide, or troponin T, which is a enzyme excreted by the heart in low levels when you have amyloid infiltration. And EGFR stands for the estimated glomerular filtration rate, a measure of renal function. So 2 measures of heart function, 1 measure of kidney function, along with measures of monoclonal proteins. The monoclonal proteins are essential to find out if someone has a substrate for AL amyloid and whether they may have that particular form of cardiac amyloid. And these biomarkers, as shown in these various graphs here, are used in what's called staging systems to prognosticate and try to inform the doctor, the patient, and family members how severe the amyloid is. And in general, the higher your BNP, the higher your troponin, and the lower your kidney function, the worse people do with the various forms of amyloid by the various staging systems. We recently published this paper with colleagues from the University of Washington, in which we also looked at some simple metrics that can be used, particularly in transthyretin amyloid, to prognosticate. This is the famous New York Heart Classification System, where we simply ask a patient what they're able to do. Are they unlimited in their exercise capacity? Do they have mild limitations? Do they have moderate limitations? Or God forbid, are they short of breath at rest? And these are what we call survival curves, in which you can see the percentage of people. Here's 100% surviving over time. People with class 1 do much better than class 2, 3, or 4. We've also noted here that the daily dose of diuretics that patients are getting is also prognostic. And our clinical experience with TTR amyloid, as people get worse, or patients get worse, they require more and more diuretics over time. And as a result, their prognosis, that is their survival, is very tied to the dose of diuretic. That doesn't mean you shouldn't increase your diuretics if you need them. This is just a marker of the severity of disease. And notably, we found that whether you use the Mayo risk model that uses BNP or troponin, or the UK model that uses BNP or renal function, when you added the daily dose of diuretic, we were able to improve, if you will, what's called the area under the curve. This is the prediction of the model, and we were able to improve it significantly, suggesting that adding to the current biomarkers, New York Heart Class, and the daily dose of diuretics could inform, again, patients, physicians, and family members about how one is doing. There's general treatment for cardiac amyloidosis that's highlighted here, and it's very important. These are not targeted treatments, for the amyloid, but these are general management strategies that are essential for all patients to adhere to. One is that many patients with amyloid are very fluid overloaded. They tend to be salt avid and retain water. And as a result, they get swollen, their bellies get bloated, their legs get swollen, and they feel fatigued because they're carrying around a lot of extra weight, and they feel short of breath. So the mainstay of therapy is to use diuretics, particularly what we call bioavailable diuretics. These are diuretics that are well absorbed in the intestinal tract, along with a very weak diuretic called an aldosterone antagonist. And these two together, we found, are quite helpful at basically keeping one's volume status, that is the fluid in the body, well regulated. Patients need to record their weight on a daily basis and be in close contact with their amyloid specialist, because rapid or changes in weight over hours or days is really not indicative of muscle gain. It's indicative of fluid retention. Calcium channel blockers are drugs that are often used to treat high blood pressure or fast heart rates. Particularly a drug called verapamil binds avidly to the amyloid fibrils in the heart and can cause the heart not to pump well and cause the heart to slow down too much. So particularly verapamil and another drug, cardizem, are calcium channel blockers that should be avoided in patients with amyloidosis. Standard heart failure medicines, including what we call ACE inhibitors, angiotensin converting enzyme inhibitors, angiotensin receptor blockers or ARBs, and beta blockers, which are used for patients without amyloid cardiomyopathy routinely, are not well tolerated by patients with amyloid, and in our experience may be associated with worse outcomes. So they should be used cautiously and often, if at all, at low dosages. Many patients with amyloid develop atrial fibrillation, and all of them, irrespective of other scoring systems, if you have AFib, need to be put on a blood thinner because there's a very high risk of a clot forming inside the heart and a stroke developing, God forbid. As the disease progresses, patients get a low blood pressure, sometimes needing stockings to support their blood pressure, push the blood that's collecting in the veins in the leg back to the heart to raise the blood pressure. And there's sometimes a drug used called midodrine to raise the blood pressure. And AICD stands for automatic implantable cardiac defibrillators. These are devices that are placed to prevent malignant fast heart rhythms. They're not often needed in my experience in amyloid patients, but about a third of patients minimally, and as the disease progresses, maybe even half, will develop what we call conduction disease, such that the heart can't pump at an usual rate. It slows down too much, and a patient needs a pacemaker. This is a picture or an echocardiogram of a patient with amyloidosis. Each one of these little dots shown over here is a measurement stick that measures essentially a centimeter. The normal heart is about this thick, about 1 centimeter thick. And I think everyone can appreciate here that this heart is probably 3 centimeters thick, 3 little white dots. This heart is filled with amyloid, and this is the left ventricular chamber, which is very tiny and small. Compared to the left atrium, you can see what I'm pointing to here, which is even larger. That's not normal. Normally, the atrium is smaller than the ventricle. The reason this ventricular chamber got so small is the amyloid infiltrated the chamber and made the heart unable to fill very easily. So this is what we call a restrictive cardiomyopathy. I like to describe it to patients like a balloon, but not a balloon made of rubber, but a balloon made of leather. It's very hard to blow and expand or fill. And as a result, the capacitance, the chamber size of the ventricle, gets smaller and smaller. And that's shown in this kind of cartoon here, where this line in blue represents the size of a normal heart, holds about 100 milliliters of blood. And with amyloid, you can see the chamber size gets over time smaller and smaller and smaller. It may go from 100 millimeters almost down to like 60 millimeters. So a large decline in the capacity of the heart to fill with blood. As a result, the amount of blood that the heart pushes out or pumps, which is the difference between this blue line and this blue line, you can see pretty wide here, tends to decline over time. And that's called the stroke volume. And when the stroke volume goes down, the output of the heart declines. So your cardiac output is going down. And as a result, patients with amyloid often have a drop in their blood pressure from 130 or 140 all the way down to less than 100. This is one of the reasons why such patients don't tolerate these medicines, the beta blockers, the ACE, the ARBs, or ARNI therapy, because these medicines all lower one's blood pressure. If your blood pressure is already low, it's difficult to tolerate these typical therapies for other forms of heart disease, not for amyloid. This has highlighted the concerns we have about these medicines in this data that we've accrued at our center, in which we compared patients who were taking beta blockers and continued on them, shown in the red, and patients who we discontinued or stopped the beta blocker. And this is a picture, again, that looks at survival at various time periods, 2, 4, and 6 years. And you can get the sense that the green line is higher than the, if you will, orange or red line at all time points, indicating that people live longer when we stopped the beta blocker than when we continued it. So I always like to say, in this circumstance, an amyloid less medicines, particularly those for heart disease, may be more beneficial to individual patients. You obviously should speak to your referring provider and not stop medicines, because they may be given for particular clinical indications. I mentioned atrial fibrillation. It's nearly universal in patients with amyloid in my experience over time. When I follow people for 5 or 10 years, almost 90% develop AFib. In large series, when we first meet the patient, about a third of them have AFib. And in the ATTR-ACT study that we conducted that evaluated tafamidis, we had a prevalence of AFib in about 53% of patients. And in regular cardiology, we use a scoring system to decide who should get a blood thinner. But in amyloid, we don't use the scoring system. If you have AFib, we give you a blood thinner. What blood thinner can you use? Well, in our center, we use both the old blood thinners, so-called warfarin, which requires monitoring, and these novel oral anticoagulants, drugs like digitriband, which is Pradaxa, Eliquis, which is apixaban, or Xarelto, which is rivaroxaban. And these agents these p-values represent no difference, seem to prevent strokes equally well to the old-fashioned blood thinners in patients. So we have observed some increased risk of bleeding. So for AL amyloid, those patients out there that we're talking to today who have amyloid in the heart that's due to the light chain, this is the disease in which the cardiologist is a second fiddle. The hematologist is playing the primary role. Why? Because there's a plasma cell and it's making too much of a protein, and you need to receive from the hematologist what I would call anti-plasma cell therapy. Some people would call this chemotherapy. And the long message here, we're not going to go into each of these different therapies, but there are a whole host of choices that cardiologists and hematologists and amyloid experts can make to essentially give drugs to lower the plasma cells' production of the light chains, which is the protein that's causing the amyloid formation. And that's an important name of the game. The most important new drug that's out there is a drug called daratumumab, or Darlex. And I would call it a new standard of care for people with AL amyloid, particularly AL cardiac amyloid. Daratumumab is a monoclonal humanized antibody. So it's an antibody that in humans we won't reject or make antibodies to, and it targets a protein called CD38. This protein is on top of plasma cells, and so because the antibody targets things on top of the plasma cells, it can destroy or stop the plasma cells from making the light chains. And there was a trial called Andromeda, should have a second A here, and that trial basically gave patients either standard chemotherapy, Cyborg-D, which stands for Cytoxan, bortezomib, which is Velcade, and dexamethasone by itself, 3 drugs, or Cyborg-D plus Dara. And the long and the short was that the chance that you would lower your light chain was literally 5-fold greater with daratumumab than with the standard treatment. And when you lower the light chains, then the organs you can see start to improve or get better. In this case, the heart, the kidneys, and the liver. And so for most patients that I see who have, for example, newly diagnosed AL cardiac amyloid, we start them on a daratumumab along with standard therapy, including Cyborg-D. There are some investigational drugs that you should be maybe aware of. This is what we call an antibody drug conjugate made by a company called Sorrento, in which they're taking, again, an antibody against CD38. This is what an antibody looks like. It's kind of like a Y-shaped protein, which the top part is very specific and binds to the receptor on the plasma cells. This is the CD38 receptor, and they can link this antibody to a drug. This drug is called Duostat, which is a tubulin inhibitor. And so by delivering or combining these two, you can get an effect like you see here, in which the antibody drug binds to the receptor. The receptor takes the drug inside and the antibody inside the cell, and you basically use the antibody to deliver the drug that can then destroy or stop the plasma cell from doing what it does. In this case, it disrupts something called microtubules, which are important for DNA to work. So this is a novel treatment that's now being started for patients who have, or tested, I should say, for patients currently who have what they call relapsed or persistent AL, cardiac amyloid, or AL amyloid in general. I pause for a minute to tell you that there are so many new studies, I can't possibly describe everyone, and I'm not aware of every study. But if you wanted to find a study that might be right for you in consultation with your providers, one essential resource is what's called clinicaltrials.gov. You can type this URL into a browser, and up comes this website in which any study that's being conducted by a pharmaceutical company needs to be registered at this site. So you can type in here, for example, AL amyloid, or other terms like cardiac amyloid with a company name, and it will bring up the individual study, including the site where it's being conducted, what the study is in general about, and how to contact either sites or the sponsor to learn more information. So I think this is really important for patients to be aware of and stay on top of. This doesn't change that much on a daily basis. You can kind of check this, monthly would be probably sufficient. So I'm going to turn my attention now to transthyretin amyloid, the other form of cardiac amyloidosis, where there's a whole plethora of emerging treatments as well. So this is the transthyretin protein. It's a protein that looks, like I said, a four-leaf clover or a tetramer. And what happens to the protein when you either get old with aging, or if you have a genetic variant, is that the protein falls apart into pieces. The pieces form these amyloid globules that form the amyloid fibrils. And when it deposits in the heart, we call that amyloid cardiomyopathy. And when it deposits in the nerves, we call that amyloid polyneuropathy. You can see that there are different spectrums of ages. Usually polyneuropathy affects people who are younger, cardiomyopathy older, but this is probably overly simplified. And to be honest, most patients, in my experience, have somewhat of a mixed phenotype in that they have maybe a lot of cardiac involvement, but some neuropathic involvement, or the opposite, and some have equal amounts. When you understand that the liver is the source of the production of the protein transthyretin, this is a piece of DNA in which we're making the protein that again misfolds into pieces that get stuck in the heart. You can come up with various strategies, which I'll enumerate here, to treat the condition. First, you can stop the liver from producing the protein. In the old days, we would do a liver transplant, which is very aggressive and rarely done anymore. But now there are drugs called antisense, a drug called inotersen or Tegsedi, small interfering RNA that's been approved, the drug called patisiran, and we're all very excited about the idea of what's called CRISPR-based therapy. CRISPR is a gene editing technique that was recently awarded the Nobel Prize this year, and that is being leveraged to treat amyloid by stopping the liver after a single infusion permanently, can't take it back, from making transthyretin. The second strategy is what we call TTR stabilization, small molecules that are taken by mouth that fit right in this spot here, in the TTR protein, and basically stabilize the protein. So instead of it falling apart into pieces, it remains in its stable quaternary or tetrameric four-leaf-like clover structure. There's tafamidis that's been approved. There's a non-steroidal diflunisal, which can be given off-label, and there's a drug AG10, which is in phase 3 clinical trials. And then there are these anti-amyloid therapies. There are abbreviations here, and I'll highlight these are only beginning to enter into clinical trials, and these are drugs that are designed either for TTR or AL to work on the amyloid fibril, which is very resistant to degradation, but try to degrade the fibril and therefore allow amyloid to be removed from the heart or the nerves in patients. So for patients that I see who have heart disease, cardiomyopathy without much of a neuropathy, there's really very little options, even though the field is rapidly evolving. You can see all the options labeled here. The most are for patients who have both cardiomyopathy and neuropathy. But since we're focusing on cardiac amyloid today, I'm going to highlight that tafamidis is an approved therapy. I'll show you the data from the trial that we conducted, but I would note that it's very, very, very expensive. In fact, ungodly expensive. And my concern is that cost could limit patients' access to it. As I mentioned, diflunisal, which is a non-steroidal anti-inflammatory, a drug used to treat pain, but at low dosages could be used off-label cautiously for patients, is something to be considered, but I think in the context of a close relationship with your provider. These are the summary data, just so you know, of patients who were enrolled in what we call the ATTR-ACT trial. It was a trial in 441 individuals, 60% who received the drug tafamidis, and 40% who unfortunately got placebo. And you can see that the average age of the patients was about 75. A majority, 91%, were men, here 88%. 3/4 had the wild type disease, so 1/4 had the hereditary form of the disease. The ejection fraction was relatively preserved. Anything above 55 is considered normal, and above 40 is considered pretty okay, so 48. And these individuals had very thick-walled hearts with high NT-proBNPs. Remember, in the scoring systems I mentioned, the cutoff for a significant disease was about 3,000, so half of them had severe disease. And the troponins were elevated as well. So this was a group by the biomarker staging system that had relatively advanced disease. But interestingly, when we asked them about their symptoms, about 70% of them had pretty mild or moderate symptoms. I take this as an encouraging finding as an amyloid doctor, because these individuals are elderly with pretty affected hearts that are thick, that have elevated biomarkers. And the fact that they don't have severe symptoms means that this condition, in my mind, is very slowly progressive, and that there is an opportunity to really diagnose patients much earlier than we're currently diagnosing them if we just pay attention more carefully to patient symptoms. In the study, we compared the effects of tafamidis in a very uncomplicated statistical method. I won't go into details, but in general, patients on tafamidis were compared to patients on placebo with regard to events such as, God forbid, who passed away, and if someone passed away sooner, that was unfavorable, obviously, than someone living longer, and how many times they were in the hospital for cardiac reasons. And the bottom line is what we call the win ratio, how many times tafamidis was better than placebo. It was about 70% more often better than placebo. But probably most importantly here, you can see that it reduced the chance of dying absolutely by 13%. And that is, for those who don't understand, a very, very effective drug. That's kind of shown here, in which we looked at the, God forbid, chance of dying if you had transthyretin cardiac amyloidosis, and it was reduced by 1/3 in patients on tafamidis compared to placebo. And similarly, there was a 32% reduction in the rate of hospitalization. We also used something called the NNT, the number needed to treat. So if we treated about 8 patients, pretty few, we can prevent 1 person from dying. And if we treated 4 patients, we could prevent 1 patient from being in the hospital. So this drug has a very high effect rate on very meaningful endpoints, usually to patients. As well, it tended to slow the decline in what we call the 6-minute hall walk, which is a test of how far you could walk down a hallway in 6 minutes up and down. And as you can see, even in the people on tafamidis, there was a decline from by about 25 meters, and here at 12 months, 25 meters, I should say, about here. But the decline in people who were getting placebo was much greater, was about 60 meters. So this is kind of the difference between able to walk, 1 or 2 blocks in kind of a city or so forth. So tafamidis tends to slow the decline, but unfortunately didn't make, on average, patients walk more. And patients reported their quality of life was better on tafamidis than on placebo, but again, did make people feel better, just slowed the decline. These data lead us to want to develop new and more effective therapies than tafamidis, even though it is quite effective. One of the important messages of the tafamidis trial that hasn't been well promulgated is the fact that when patients are diagnosed earlier, these are patients with what we call NYJ class 1 symptoms. So they're basically unlimited in what they can do, but they were diagnosed with amyloid. We only diagnosed 37 of them out of the 441 in the trial or the study. They had a reduction in mortality of 64%, whereas those who had mild or moderate symptoms, which was the majority of the patients, they had a reduction in mortality with tafamidis of 39%. And more advanced patients, which unfortunately many were diagnosed in an advanced state and enrolled in the study, had less of a benefit. So this teaches me that I really want to try to identify amyloid as early as possible to leverage the benefits of emerging therapies. So the success of the tafamidis trial has led to a wealth of what we call phase 3 clinical trials. These are studies that, if they're effective, these drugs will then be on the market, available to patients, hopefully soon. So one trial is a drug called AG10, Attribute CM. It's a drug that's very similar to tafamidis. The study is fully enrolled. The plan was to enroll 510 patients. They gave 2/3 of the patients the active drug and 1/3 placebo, and it's designed very similar to tafamidis. And we'll learn more about whether this so-called super tafamidis, an oral stabilizer, is better than tafamidis, or at least effective on its own after the reporting out of this particular trial. There's a drug patisiran, which is an IV administered drug every 3 weeks that's already on the market for patients with amyloid in the nerves from a genetic cause. They can have amyloid in the heart as well, but they have to have the hereditary form of amyloid to get the drug commercially now. And it's being tested in a trial called Apollo-B, in which 300 participants are being enrolled. Again, this is, I believe, nearly complete enrollment, 1-to-1, to see if this drug in patients with transthyretin and cardiac amyloid is better than placebo. And the primary endpoint in this study is how far people walk up and down the hallway. And then there are 2 new, what we call sub-Q silencers. These are not administered intravenously, but are administered like insulin underneath the skin. One is an antisense compound made by Ionis or Axia, has just a number, and it's a very large trial in patients who 1-to-1 get the drug. And then there's Helios-B, a new drug called vutrisiran that's administered not every month, but every 3 months, enrolling about 600 participants, again, looking at hard endpoints to see. So we may have, God willing, a new stabilizer on the market at some point, and we could have 3 new silencers at some point available for patients with cardiac amyloid if they're all effective. What is the idea behind silencers? This is called small interfering RNA, or an antisense oligonucleotide, is that you're making a protein that is unstable, that basically falls to pieces, gets stuck in the organ and causes the disease. And by blocking the production of the protein and lowering the level in the bloodstream, you can reduce the level, you can prevent the deposits in the organ, and ideally stabilize and maybe even recover or reverse the organ dysfunction. That is what's happening in the heart. These are kind of compelling data from the original study that was published in the New England Journal of Medicine of the drug patisiran, again, in patients who had amyloid polyneuropathy, so in their nerves was the amyloid due to a genetic cause, but many of these patients had concomitant cardiac involvement. And in this study, the investigators measured the hormone NT-proBNP, which is a measure of how severely affected the heart is. At the beginning of the study, both groups had a mild elevation of about 700, and you can see those on placebo, the values tended to go up, which is not good, getting higher and higher over time. And the people who were receiving the silencer or patisiran, the cardiac biomarker BNP tended to go down. And these differences are highly statistically different. And we hope that they'll translate into a clinically meaningful effect, that is, will translate into patients living longer, functioning better, or feeling better. Additionally, when we did some analyses on this study, we found out that patisiran made the wall less thick than placebo. It made a shortening of the heart. I'll show you pictures of this measurement strain a little better. And it basically tended to reduce the decline in the capacity of the chamber, like I was showing you before. Remember, the heart was getting smaller and smaller and couldn't hold a lot of blood. It declined quite a bit. The capacity of the heart on placebo went less with the patisiran. And the mass of the heart, that is how much it weighed, also estimated from ultrasound, went down. Presumably this was due, we thought, to amyloid being removed from the heart or regressing. Additionally, in the same study, investigators used a very sophisticated technique to measure heart shortening. So this is the left ventricle, like I showed you before. This right here is the mitral valve opening and closing. Here is a left ventricle that's got a good capacity. Here's the left atrium. Blood rushes from here through the valve into the ventricle. And you can see the ventricle shortens. And we can use a technique called strain that puts a little label on the myocardium and measures the shortening between each of these little dots and color codes the shortening. Red is muscle that's shortening very well, and pale or blue is muscle that's shortening not very well. And you can see the tip of the heart is shortening well and the base is not. This is a typical pattern in amyloid. And when they measured the effect of patisiran on what we call regional, various areas, they found out that at the basal region here, where the heart is shortening the least, where there's probably a lot of amyloid, there tended to be an effect of the drug on that. And so this was further corroborative evidence, or hopeful, that this drug may help myocardium or the heart. Further evidence comes from pictures like these. This is MRI data in which they use a technique to measure what's called ECV, or extracellular volume. The heart has muscle cells, and around the muscle cells is tissue, and that's where the amyloid lies. So when your extracellular volume expands, that usually is a good measure of the degree or amount of amyloid in the heart. And what they measured here is the change in extracellular volume. And you can see that the change is lower in people who were treated than those who were not treated over a year's time period, suggesting that on average, there may be amyloid at least not getting worse and maybe even coming out of the myocardium. It's all very suggestive. As I mentioned, there are not only drugs to silence the protein, but there's this gene editing technique called CRISPR-Cas9. This is a gene editing technique that, as I mentioned previously, was just awarded last year the Nobel Prize. And it's a way to get rid of unhealthy genes. And so for TTR, you could deliver a gene editing technique in what's called a lipid nanoparticle. That lipid is infused intravenously. It'll go to your liver. The liver cells will take up the little gene editing scissor. And basically, after a single administration, it'll chop out the area of the DNA in the liver cells or hepatocyte that's making TTR. And so your liver will do everything it's supposed to do, make all the other proteins, make cholesterol, make clotting things, but will no longer make transthyretin. So the levels will come down in the bloodstream. And this would be potentially a revolutionary therapy that after one infusion could literally silence the production of TTR and would not require, you would not make it anymore. One essential important point for patients who are taking silencer therapy is that you no longer have the protein that carries your vitamin A around. So for the rest of your life, not a big deal, you need to take vitamin A supplementation. In these studies that we're conducting, we always give people vitamin A supplementation. So CRISPR is what's called the molecular scissor, and kind of edit out the proteins that we don't like. It's kind of revolutionary. So transthyretin amyloid, I would say, has gone in a very brief period of time from a rare zebra to one that we're recognizing much more frequently and hopefully earlier. We didn't touch upon this today, but we can now make the diagnosis in upwards of 80% of patients with a scanning technique and don't need to do a heart biopsy. And there's a lot of new treatments. And so there's a growing interest in this disease. I want to just finally end with the emergence of what we call anti-amyloid therapies. These are drugs that are targeting the amyloid that's already in the organ. As you saw, patisiran, as an example of a silencer, may shut off the production of the protein. We know this from the world of AL amyloid. When you stop producing the protein, the body has its own natural mechanisms to potentially remove amyloid from organs. But these drugs named here are all attempting to accelerate that process. And they usually use monoclonal antibodies that target the amyloid and try to bring additional what we call macrophages. These are cells that we have that can kind of like Pac-Man eat up the amyloid. The different drugs, there's one called PRX-004 made by a company, Prothena, where they completed what's called a phase 1 study. So they figured out maybe the dose. There's NEOD-001, which I'll highlight in a minute, again, made by Prothena. They had a phase 3 trial that did not work, but they found an interesting signal, and they're conducting another phase 3 trial in people with advanced AL amyloid. There's an antibody made by a company called Calum, which they're doing a phase 3 study. And then there's a company, Neurimmune, that has an antibody, and Atralis has another antibody that we would call preclinical that hasn't even begun to get into humans, but you may want to pay attention to. This is the NEOD-001 antibody made by the company Prothena, which they've renamed Vertimimab. And while they conducted a study called VITAL, in which newly diagnosed patients with AL amyloid got standard treatment, that was the anti-plasma cell therapy we talked about before, like Cyborg D, the Cytoxan, the Bortezomib, or Velcade, and the dexamethasone. That trial overall was negative or neutral. They didn't find an effect of this antibody on the endpoints they were looking at. But in a subgroup of patients who had the worst disease, they found that the drug, compared to standard of care, patients, again, these curves are indicating who's alive. Everyone starts alive. More patients are alive over time with this antibody, along with anti-plasma cell therapy than antibody alone. And this led this company to ask the FDA if they could repeat a study to confirm this finding, which is required before we have confidence that this is a real effect, not something that is a kind of a statistical fluke. This trial is enrolling currently, I believe. And then there's this antibody, Calum 101. We did this study here at Columbia, which was a phase 1 study in patients with relapsed or refractory AL antibody amyloidosis. And this is a small subgroup. It was only 27 patients. And you can see here, this is the subgroup of patients who had AL cardiac amyloid. This is the name of the antibody. It's called 11-1F4. And this antibody, we measured the change in the BNP. That's the hormone that goes down. When it goes down, it's a good thing. And if it goes down in patients by more than 300, if they start at a baseline of greater than 600 and or more than 30%, that's considered a good response. And you can see there were some patients who had that kind of response, these dark blue lines shown below the red. And overall, almost all patients had either a response or some stability. No patients after this antibody, which was only administered once a week for 4 weeks in this trial, seemed to have some efficacy. We also showed, this is again this strain that I showed you before, and in addition to looking at the regional values, you can ask the computer to tell you what the global strain is. You can see down here it says global strain minus 12%. That's how much the heart is shortening. The more negative it is, minus 20 is better than minus 12, is better than minus 5. The more the heart is shortening percentage, the better it's doing. And you can see here that patients at baseline had a value that was about minus 16, and they tended to get better on average, shorten better after only 12 weeks on this therapy. Again, raising hope that this could be removing amyloid and might be affecting the heart function. So I will conclude and open the discussion to your comments and questions, but I wanted to conclude by saying that amyloid cardiomyopathy is what's been called by one of my colleagues, Claudia Rapezzi in Italy, the great pretender. It's a disease that masquerades as others. People thought of it as a challenging disease in medicine that's fascinating and mysterious. I would point out it's not as rare as we thought. We try to encourage providers to think about it, because when you think about it, it's relatively easy to detect. And I want to encourage all the patients who are suffering from this condition to realize that there are a wealth of treatment options that are being developed. This condition is very manageable and treatable, especially when you're in the hands of someone who has significant expertise. And most importantly, treatment is more effective, obviously, when administered early in the course of the illness. Again, thanks for your time and your attention.
Hello, thank you for participating in this session. My name is Kai Taylor and I'm the moderator for today's session. You're joined today by Dr. Matt Maurer from the Amyloidosis Foundation. As a reminder, the Q&A box is located on the right-hand side of your screen. To submit a question, type your text into the text box and hit the Ask button. Please note that due to time constraints, our instructor might not have time to respond to every question. This time, I would like to turn the microphone over to our presenter for any questions. Thank you.
So thank you very much, and I appreciate everyone joining today. I hope the pre-recorded session was useful, and we have a wealth of questions in the chat box. I'll just get started. Someone asked about cardiac transthyretin amyloidosis, and also notes that they have amyloidosis in their digestive system. And they wonder whether or not there could be any absorption issues with tafamidis. And if there's anything that impairs absorption, if there's anything that they can do about that. I don't think there are any major absorption issues with tafamidis. Notably, the absorption of a drug is a term in medicine called its bioavailability. Many drugs that we put in our mouths do not get well absorbed, but tafamidis does. Actually has quite a long half-life, which is why it is dosed once a day. In fact, the half-life of tafamidis, for those of you taking it, is about 51 hours. And so, God forbid you miss a dose, there's plenty of it in your body for a long period of time. I would note, though, regarding absorbing of drugs, many patients with cardiac amyloidosis need to take diuretics, particularly diuretics that are what we call are loop diuretics. These are diuretics that work a particular part of the kidney called the loop of Henle. And these are potent diuretics. You may know their names as furosemide, otherwise known as Lasix, because it supposedly lasts 6 hours. There's another diuretic called bumetanide or Bumex. And then there's an additional loop diuretic called torsemide or Demodex. And people, I think, should note that those three diuretics differ in what we call their bioavailability, that is their absorption. Lasix is very poorly bioavailable. And so you could put a lot of Lasix in your mouth, say 80 milligrams, and you might only absorb 8 or 10% of it or 15% of it. So we're talking 8 milligrams of the 80. And that's because when your body gets full of water, sometimes you'll see edema in your legs and your legs get swollen. So can the wall of your intestine. And so these drugs are not, that is, well absorbed. And so Lasix is poorly bioavailable. Bumex or bumetanide and torsemide are better bioavailable. And so one thing we'll often do is switch a patient from a less bioavailable diuretic, Lasix or furosemide, to torsemide or bumetanide. So, but again, one other aspect of tafamidis, or what's now called Vyndaqel or Vyndamax, is the kind of commercial names, is that it comes in 2 different formulations. The drug was originally developed by a colleague, Jeff Kelly, in his laboratory at Scripps. The original formulation is called tafamidis meglumine, in that the active drug tafamidis was linked to a salt, and that made it, somewhat soluble. The problem is that they could only fit 20 milligrams of the drug in a pill, as many of you who do take Vyndaqel, the tafamidis meglumine, know that's very, very large. And so then to take 80 milligrams, you have to take 4 of these horse pills every day. When we learned that the drug was effective, Pfizer reformulated the drug into what's called tafamidis free salt. So there's tafamidis, the active drug with no meglumine, no attachment. And that's called tafamidis free salt or Vyndamax. And that's 61 milligrams available in a single, much smaller pill. So it's much more soluble. So I hope that addresses the issue of absorption of tafamidis. Someone asked an excellent question, which was, is there a way to tell if you have cardiac amyloid without a biopsy of the heart? This person noted they have it in their tongue, colon, and kidneys. So, there is a non-biopsy approach to make a diagnosis of transthyretin cardiac amyloidosis. Again, to remind people, there are 2 main forms of cardiac amyloidosis. A majority of patients, well over 95%, have either AL or light chain amyloid or transthyretin amyloid. You can pretty definitively arrive at a diagnosis we call a non-biopsy approach by using what in the United States is called a PYP scan. PYP stands for the isotope.
that is injected. It's a bone-seeking isotope. It's been used for 50 years in medicine to image the bones. And for reasons we don't completely understand, when you inject it in a patient who has transthyretin amyloid, their hearts glow in the chest on this imaging. That test, the scan, needs to be coupled with a blood test to make sure that you don't have any substrate for AL amyloid. You don't have any light chains or monoclonal proteins. So there is a way in transthyretin amyloid to identify the disease without a biopsy. For AL amyloid, there's no definitive way to know that that's what's in the heart without a biopsy. Though in many times, we often assume that if a patient has light chain amyloid, for example, in their kidney or in their colon or tongue, which is what this patient is describing. So it sounds like they could have AL, and we see a thick-walled heart that looks like amyloid on ultrasound. Even though we didn't do a biopsy, we often conclude that that heart is affected with amyloid, and you can often infer things from the echocardiographic or ultrasound images, and also can infer things from like an MRI. And that often is very, very true. I only say often because we just recently encountered a patient in our center who we all presumed had AL amyloid in his heart. He was an older gentleman, so he was at risk for the other form of amyloid, transthyretin. We knew he had AL in his peripheral organs. We were treating him for years for AL, and it turned out he had two forms of amyloid, one in his periphery and one in his heart, that were different. So, never say never in these circumstances. Someone asked about a question about persistent GI issues, and is this part of amyloidosis? And most certainly it could be. Gastrointestinal complaints are not uncommon in people with amyloidosis, and probably are, in my experience, listening to patients, one of the more upsetting things that they experience, especially in patients, for example, who have neuropathic forms of amyloid, in which the transthyretin protein affects, if you will, not only the heart, but can affect the automatic nerves that regulate your intestinal motility or your movement of your intestines. And those patients often have very severe GI symptoms with alternating constipation and, God forbid, diarrhea. It can become a real source of embarrassment because they could lose their bowel function at any particular point in time. We don't see as much GI issues that we're sure are due to amyloid in patients with so-called age-related or wild-type transthyretin amyloid, but that may be a function of the fact that patients aren't talking about it with the cardiologist like myself. We definitely see quite a bit more in AL and in the variant forms of transthyretin amyloid. Someone asked, I'm currently on Vindamax, 61 milligrams, and how effective is this medicine over time? I think that's an excellent question. What we know from one single moderate-sized study that led to the approval of tafamidis, that the drug was quite effective at reducing the chance, God forbid, of passing away or being in the hospital, in that it reduced those chances over about a 2.5-year period by about 30 to 35%. Sometimes in medicine, we use a concept called the number needed to treat. How many people do you need to treat in order to prevent an event? So we needed to treat about 7 to 8 patients with tafamidis to prevent one person, God forbid, from passing away. And we needed to treat only 4 people to prevent one person from being in the hospital. Those numbers are quite stupendous for a drug because, obviously many other therapies have number needed to treat of 50 or 100 people. Having said all that, the question here is how effective is it over time? And we don't have long-term data. I can tell you that the drug is more effective when administered early in the course of the illness. So those patients who have less amyloid in their heart are more functional with less symptoms. They tend to do better with tafamidis or Vindamax or Vyndaqel than patients who have more advanced disease. And I always like to tell this story. I do have one person, actually 2, now that I think about it, a man and a woman, each of whom have been taking tafamidis for 15 years, 15. Some people ask, well, how is that possible? And the answer is they were in the original drug development study, the phase 2 trial that we started many, many years ago. One of those individuals is now 96 years of age and is doing quite well. So there is long-term efficacy with the compound. We'll learn more over time. I would, though, state that I don't think the drug is perfect, and that's why we're trying to develop other approaches to try to treat, particularly transthyretin and amyloidosis. Someone asked, just seemingly lost my screen for a second. Someone asked about these drugs in development and how quickly they will become available. And that's, I think, a very good question. I think it's important for people to understand the drug development process. So there's what we call a preclinical phase, in which a company decides that they may have something that they can test in non-humans or in animals or in cells that are outside of the body. And then they bring the drug to what's called the clinical phase of development. And there are essentially 4 phases. There's phase 1, in which they're trying to figure out, is this drug safe at all, and what dose should they give? That's usually a phase 1 study. And those are very small, usually 20 or 30 people, to find out the right dose of the drug and determine what dose they want to bring to, if you will, the next phase. Phase 2 studies are a little bit more about safety, mainly, some maybe early efficacy, and those aren't usually very big studies either. They're usually on the order of 20 to 50, maybe 100 people in the amyloid space. And then the definitive study is the phase 3 trial, in which, as you've seen, many of these trials last for, a duration of 2.5 or 3 years. It also takes us time to recruit all the patients to enroll in the study. Thankfully, many patients with amyloid are very willing to enroll, and we're very grateful for that, because they can help us accelerate the development of new drugs that hopefully will help people. But if it took a year to recruit the whole population, which sometimes it takes longer, usually sometimes 1.5 years or 2 years, and it takes 3 years to complete the study, and then everyone has to analyze the information for another 1 or 2 years, you can get the sense that it could take upwards of 5 or 6 years for a drug to really hit a phase 3 study and then get on the market. And obviously there are phases before phase 3. So it takes a long time. That's why I encourage my patients who are eligible for some of the upcoming studies, if they think it could benefit them, to enroll, especially because you get potentially access to the drug much sooner than other people would before it becomes commercially available. Someone asked a question about a wild type transthyretin amyloidosis. They had a heart transplant 4 years ago. I say congratulations. That's not done quite frequently in the United States. When we last looked, there were 66 transplants in the entire United States done per year for people with amyloid, so it's pretty rare. But they were asking what other things can happen in other parts of the body after a heart transplant. And this is a very good question, in that thankfully the amyloid does not appear often to come back inside the transplanted heart. And we have a relatively large cohort at Columbia. We've transplanted somewhere between 45 and 50 people who are eligible. And we have not seen recurrent amyloid in what we call the graft or the new heart. We have seen, however, people develop amyloid deposits in other organs, like we've heard, particularly in AL, it can go anywhere. So in light chain amyloid, can go into the kidney, can go back into the heart and go into the lungs, the liver. And those patients really need to follow up carefully with their hematologist. For wild type disease and for variant disease due to transthyretin, we thought that there would be really no problems, because the main problem in wild type was in the heart. Why would it go anywhere else? But we have observed that amyloid can deposit in other organs and cause symptoms. And we actually are trying to leverage the newer emerging therapies for such patients to make sure that the amyloid doesn't get stuck in another organ. So we do have a report out about that that's under review, and hopefully be published. And the Mayo Clinic has reported similar findings. Someone asked, in the future, would a person with wild type take a stabilizer like Vindamax, a silencer like a small interfering RNA, and a depleter like PRX-004? Would they take all three? And it's a great question. We don't know. Drugs are not studied at this point in combination. I have a very few patients who are actually on combination therapy, and we actually don't know if combination therapy is better than any of these single drugs by themselves. It's something that we need to really investigate further. Obviously, this person's quite erudite. They asked about 3 different mechanisms. So that always makes biologic sense to try to target something not with the same mechanism, not using an antisense and a small interfering RNA, both of which are silencers together, because that wouldn't make too much sense. But this is a possibility. I think one of the issues, though, is, as many of us know, is cost. If each of these drugs costs $250,000 to $500,000 a year, is that all going to be feasible? Trying to take a few of them. So I apologize not having a better answer for that. Someone asked, I know that wild type TTR is not hereditary. They wrote supposedly. Has there been any indication presenting in family members? So the short answer is there have been, very rare and unusual case reports in which people have reported that, 2 brothers, for example, have disease, but they're both elderly men. There's no evidence in those reports that I'm aware of that anyone's ever found a genetic cause. There must be modifiers, though, of this particular condition. And one research study that's underway, starting in Europe, but in the US we'll be participating, is to do what's called whole genome sequencing in patients with wild type TTR to try to see if there are any explanatory genetic modifiers that might explain why someone might get the disease, for example, earlier, not so age related, in their 50s or 60s, and why someone else gets it in their 80s. But at present, we, I think, tell people, and I think it's true, that your family members don't have to be worried if you have a wild type disease. There's no evidence that you should be concerned about that. Someone asked, should someone who has a heart transplant and wild type take some types of treatment? So this is similar to what I mentioned before. Many of the patients who have transplants were excluded from the clinical studies. But there's emerging evidence to suggest that minimally patients post any organ transplant should be followed by the amyloid center and experts there to see if they're developing any disease, not only in the transplanted organ, which I said is uncommon, but in other organs. And certainly if there is evidence of that, I would strongly advocate for consideration of some therapy, be it tafamidis or an available silencer. Someone asked a great question about fatigue. What causes me to basically want to sleep all day long? In cardiac amyloid in particular, the cardiac output, the amount of blood that the heart pumps every beat, is markedly reduced. A normal heart pumps about 70 milliliters of blood every beat. And if it pumps 70 times a minute, you can do the math. 70 times 70 would give you 4,900 milliliters of blood pumped out of a normal heart every minute. That's pretty close to 5 liters. And we also normalize that number, that's called the cardiac output, to the size of the patient. So you can imagine a mouse doesn't need a lot of output, an elephant needs a lot of output. So the taller you are and the bigger you are, you get. And when you divide the cardiac output, say 5, by what we call the body surface area, which is normally about 2, that's how big you are. It's a calculation based on your height and your weight and other things. You would get a cardiac index above about 2.5. So 5 divided by 2 would be 2.5 milliliters of blood circulating around for your body size. In amyloid, it's almost always below 2.2, which is abnormally low. And that inadequate output can, I believe, contribute to some fatigue, because essentially the heart is trying to provide oxygen to all the tissues, and it doesn't provide enough oxygen. And as a result, people often complain of feeling very profoundly fatigued. Someone asked a question about AL cardiac amyloid and the need for a stem cell transplant. And what are the things that might exclude someone? Well, so a stem cell transplant is where they take out peripherally through a kind of a machine. They clean your blood and find the stem cells, and they put them in a freezer to hold on to them. And then they give you very, very high dose chemotherapy enough chemotherapy that essentially wipes out your entire bone marrow. So it kills all the plasma cells and all the other cells. And then a few days later, you infuse, the stem cells, not a few days later, simultaneously, and those stem cells can repopulate the bone marrow. So this is the most effective way that we know of to really kill plasma cells that are making the light chains that are getting stuck in your heart. It's a pretty aggressive treatment. It puts a lot of stress on the body. For people who've had it, you can talk to them, certainly in support groups, but you're at risk for getting a serious infection because they wiped out your bone marrow. You can get fluid shifts and arrhythmias. And so the biggest factor that dissuades people from even considering a stem cell transplant is significant cardiac involvement. So I, as a cardiologist, will often see patients for my hematological colleagues who are asking, is this person able to go through a stem cell transplant? And in reality, we use a lot of factors that determine that. One is the age. If someone's much above 70 years of age, they don't have a much usually reserve. We don't advocate for a stem cell transplant. If you have significant cardiac involvement, what I mean by that is really severe symptoms, New York Heart Class 3, you're short of breath with minimal activity. If your cardiac biomarkers are very elevated, if your troponin is high or your BNP is very high, that would put you at a high risk. In amyloid, usually the heart gets thick and can't expand and becomes leathery and can't fill, but the pumping capacity or the ejection fraction is preserved. But if your ejection fraction is reduced, that's kind of a later phase phenomenon, and that would also put you at higher risk. And this patient noted that their ejection fraction is 35%, which is low, especially for amyloid. So this is a complex decision that needs to be made by someone who has experience along with the hematologists. Having said all that, I can tell you about a patient who had a low ejection fraction, who wasn't responding to the multitude of new chemotherapeutic agents. And so we didn't have much of a choice about pursuing a stem cell transplant. He happened to be quite young, in his mid 40s, and we did it despite it being high risk, and he did very, very well. So there are rules, but it's a very complex and should be an individualized decision. There's, I wouldn't comment, a very rare need nowadays in many patients with cardiac involvement to pursue stem cell transplant, in part because we've developed, or not we, the community has developed so many effective drugs. If people aren't aware, for AL amyloid, there's a newly approved and first approved therapy that stands, that's called Darlex or daratumumab. It's I mentioned it in my talk. It's a monoclonal antibody against a protein on the plasma cell called CD38. And it's very, very effective at lowering the light chains and stopping the production of light chains by the plasma cells. So there are lots of options and alternatives that are emerging that are quite effective and often can obviate the need to consider a stem cell transplant. I apologize for the little cough. I have an allergy. Someone asked, what does JACC stand for? JACC stands for the Journal of the American College of Cardiology. And that's just, in some of my slides, I noted the citation where a particular study was taken from. There are other journals that are noted there, so I apologize if that was any confusion. Someone asked, amyloid deposits in TTR and AL are composed of various elements. Can you contrast the differences between the deposits in AL and TTR? They specifically want to know about available treatments affecting existing amyloid. So this is a great question. Obviously, the precursor protein that forms the amyloid fibrils is different from AL and TTR. And therefore, if more amyloid is going to be formed, it's from a different precursor. That's why it's so important to know what type you have. But to this excellent question, the deposits aren't just composed of the amyloid. There are what we call proteoglycans and other proteins that are there. There could be reactive in the interstitium, meaning between heart cells. There could be fibrous tissue that reacts, leading to scarring. So there's a lot biologically going on. The anti-amyloid approach, which is, can we develop antibodies that would target either AL or TTR that's already preformed, that's in an organ, say in the heart, and somehow activate the immune system to, like Pac-Man, chew up the amyloid. That's the idea behind some of the antibodies. And I think I showed in the slide, these are in development. There's one called PRX-004, which is targeted at TTR. Just did a phase 1 study, so they're trying to figure out the dose, early efficacy. There's an antibody, NEOD-001, developed by the same company as PRX, Prothena. They had some, advanced studies, a phase 3 trial that didn't meet its endpoint, so it didn't, in theory, work. But they did find that the sickest patients, in hindsight, seem to do the best. So they're restudying that antibody, NEOD-001, in the sickest patients. And there are other antibodies, particularly there's a company, Calum, that has an antibody that targets AL. And then there's one company called Atralius, which is developing an antibody that may target all forms of amyloid given their approach. Someone asked what drugs are to be avoided in TTR wild types. That's a great question. In general, the most important drug to be avoided is what we call non-dihydropyridine calcium channel blockers. It's a very long word, but there are 2 types of calcium channel blockers, ones that work on the heart and ones that work on the blood vessels. So the ones that work on the heart are verapamil and cardizem. And those drugs seem to bind avidly to the amyloid fibrils. And when they bind in the heart to the amyloid fibrils, they can cause their usual physiological effects, but to an extreme. So these drugs slow the heart rate. But if you take these drugs, they can slow the heart rate, like to the point where the heart can stop or pause. And they can impair the contraction of the heart. So if your heart's pumping well, it can slow it down a little bit and cause it to pump a little less well. But if they bind to the amyloid fibrils and they hang around, they can cause the heart to go from a pumping function of, say, 60% down to 30 very quickly. So those drugs are to be avoided. In fact, if you have amyloid, a warning sign, and you, God forbid, develop a condition called atrial fibrillation, in which many patients who go into AFib, the heart rate's not fast, but you're going very fast and you have to go to an emergency room, please tell them not to give you cardizem. Doctors almost always use IV cardizem for patients in AFib who don't have amyloid, but it's a dangerous medicine. Other medicines to be avoided are medicines that cause fluid retention. So non-steroidal anti-inflammatory drugs, very common medicines that we all take. Advil, Motrin, those kind of drugs can cause fluid retention. If you're also on a blood thinner, they can increase your risk of bleeding. Those are drugs to be avoided. There are drugs that are commonly used to treat heart disease and heart failure that in some patients probably are not well tolerated. So I don't want to give blanket statements so everyone panics. But we found that because the heart doesn't pump very well in amyloid, and I shouldn't say that it doesn't fill very well and therefore doesn't deliver a lot of blood, the ejection fraction is still preserved, but the amount of blood being pumped out of the heart is not normal. Remember, ejection fraction is the ratio of the amount of blood being pumped out of the heart, called the stroke volume, divided by how much blood the heart holds. So I always tell this example to patients. If your heart holds 100 milliliters of blood, and it pumps 70 milliliters of blood, then your ejection fraction is 70 divided by 100, or 70%. If your heart only holds 50 milliliters of blood and it pumps 35 milliliters of blood, then 35 divided by 50 is still 70%. Your ejection fraction is the same as normal, but your heart is only pumping 35 mLs. Why is it only pumping 35? Because it got stiff and thick and leathery and it couldn't expand or fill. It didn't hold 100, it only held 50. The problem wasn't the pumping, it was the filling. In such patients, usually you need to have a faster heart rate to maintain your blood flow, your cardiac output. Remember, I explained to you that the cardiac output is usually 5 liters a minute, 70 mLs times 70 beats a minute. If, however, you're only pumping 35 mLs, right, because that's what you pump in amyloid, a little less, you tend to want to pump faster, let's say 100 beats a minute, in order to deliver 35 times 100, 3.5 liters a minute. Still less than a normal heart that does 5 liters a minute. And many doctors often give patients drugs to slow the heart rate, which are beta blockers. And beta blockers, in my experience, are not well tolerated. So that's a medicine that you should consider. There's also drugs that are often used called ACE inhibitors. They're called enalapril or captopril, those kind of agents. There are also angiotensin receptor blockers like Diovan or candesartan or rebisartan or losartan. And then there's a new drug, Entresto, and many of these can lower the blood pressure quite a bit and may be not well tolerated. So there's no hard and fast rules except for the calcium channel blockers I mentioned up front and the non-steroidals that I mentioned. The other drugs really need to be individualized. So someone asked again about scanning techniques. I think I touched upon that, but there are ways to, relatively non-invasively with a nuclear camera that's usually used to image the heart to diagnose transthyretin amyloid without a biopsy. And these are readily available at many expert centers, but also at general cardiology places. Those scans must be done not by themselves, with blood tests to make sure that you don't have light chain amyloid. Their test is used not to diagnose light chain, it's to diagnose transthyretin. But if you have a positive scan, that doesn't mean it's always transthyretin. There could be a false positive scan from a light chain amyloid. And so no doctor should order these scans without also assessing for light chains with blood tests. Someone asked about ECGC, a green tea that was used in Germany in Heidelberg. In general, I don't leverage such therapies much anymore. First off, the evidence that green tea is a very good and potent stabilizer isn't there. The amount of green tea that has been shown in animals and mice that you would need to take to recapitulate what's been shown in them might make you look green, to be honest. I mean, the dosages were very high. And in the background of modern therapies, it's not intuitive to me that some of these off-label therapies that are nutritional were really are very effective. So I wouldn't personally run and endorse them. Someone asked in AL amyloid patients in what's called a CR, or complete response, which means your light chains have normalized, but needing an organ response, which we would hope would happen, which is when the light chains come down, then your heart gets better, and therefore your hopefully your biomarkers, your BNP, would begin to come down and the heart would get better. Why aren't anti-amyloid dissolving therapies made available? And I don't disagree with this question. Someone wrote, neglecting this population is in contradistinction to the mechanism. I think you're right. Those are decisions made by companies. The largest group of patients who may benefit from these are people who have already eliminated the amyloid, but do have an organ response. They've decided, for reasons you may want to ask them, to focus on newly diagnosed patients. I think they probably think that is a cleaner, more straightforward, quote unquote, group to study. Obviously, patients who are in a CR, complete response, God willing, will stay there, but they could have recurrent disease. And if the amyloid comes back, how much of that is due to new amyloid production from AL versus an inefficacy of their antibodies? But I do believe there is a much larger group of patients that may benefit if the anti-amyloid therapies would work. Someone asked, is patisiran and fitusiran the same drug? And the answer is no. They're both small interfering RNA. They're packaged differently. Patisiran is in a lipid nanoparticle. It's infused intravenously. It's given IV every 3 weeks, and it needs to be given with a bunch of pre-medications. And these pre-medicines include steroids and what we call H2 blockers that block an allergic response. So lots of medicines, including one called Benadryl, you need to take along with it, or Cerdazine. So that was the original formulation. And the way it was gotten to the liver, which is where you make TTR, is by packaging the small interfering RNA inside a lipid, a fat nanoparticle. And so it turns out that when you fuse these fats in the vein, they go right to the liver cells, and the liver cells kind of chomp them up and eat them up. Fitusiran is a more effective and potent version of the small interfering RNA, and it is linked to what's called a GalNAc, a sugar, and that sugar is specific for liver cells, what we call hepatocytes. And so this drug is no pre-medicines, just a shot underneath the skin, very little, like an insulin shot, given every 3 months, and the sugar brings the small interfering RNA to the liver and targets the liver cells to pick up the small interfering RNA. I hope that is clear. Are there currently, someone wrote, any FDA approved or pending treatments to help purge amyloid from the heart? So when you say purge, usually that, and to me, reminds me of the anti-amyloid therapies. There aren't any currently approved anti-amyloid therapies. There are ongoing studies, in particular, as I mentioned, for newly diagnosed patients. Unfortunately, like the other a patient asked, there are studies that are testing these antibodies. But for patients with established disease, I'm currently unaware of any study that any of the companies are doing, which is, again, we talked about, a little bit of a shame. Someone asked a great question. Sorry I didn't mention this. I said verapamil and diltiazem is contraindicated. Those are the non-dihydropyridine form of calcium channel blockers. Someone asked, is amlodipine? The answer is no. Amlodipine is not a non-dihydro. It's a dihydropyridine. So it works more on the blood vessels, and it's relatively well tolerated. It doesn't bind to the amyloid fibrils. It's not commonly utilized because most patients with at least bad cardiac amyloid don't have high blood pressure. They have a low, but you can take amlodipine safely. Someone asks, is Vyndamax currently the best treatment for wild type? Best is, who knows? It's the only treatment that's approved for wild type. So it's not like we know it's the best. We're hoping we will create better therapies. There are some, as I mentioned in my talk, newer therapies, including Acrometis or AG10, which is in development for both wild type and variant cardiac amyloid. And then there's also the silencer treatments. If the ATTR cardiomyopathy patient is already on tafamidis and is in the Apollo B study, that's a study in which we're randomizing people to get either patisiran, the small interfering RNA, or placebo, are there other trials that they should be looking into? And they asked, like CRISPR. So it's a great question. And the field has gotten, I'd say, thankfully, complicated because there are a lot of things going on. I don't think anyone can give you very sound advice. Certainly I can't. One thing I would note is when you're in one trial, you can't be in another trial. And we really, I think in the development of these drugs, try to discourage people from leaving one trial and going into another. Because if everyone did that, we'd never finish any of these. We'd never know which therapy is effective. I can completely understand, though, if someone's not feeling well, they don't think they're getting something and they want to try something else. But many of the trials actually have exclusions that say, if you were in a previous trial within the last year, you will not be eligible. But we should spend a minute talking about what CRISPR stands for. CRISPR is a gene editing technique, for those of you who don't know, that was recently awarded to two women who won the Nobel Prize. And it's a technique that exists in cells. Viruses use it, humans use it, where you can literally chop or cut your DNA at a particular spot that's making all of your proteins and edit them. And I think part of the reason that it won the Nobel Prize is it has such an intense therapeutic potential. And there is a company, Intellia, that is leveraging CRISPR to knock out or silence transthyretin production, that is TTR, in liver cells. If this were to be effective, this would be ideally a single infusion of the gene editing that would go to the liver and essentially tell your liver, please don't make any more TTR. It wouldn't be need to be re-administered like the every 3-month shots or every 1-month shots that are being given subcutaneously or the IV infusions. This would be a one-shot treatment. So that could have amazing therapeutic potential. At the same time, you can't take it back. So we believe that you don't really need TTR. If you take vitamin A supplements, we believe you should be fine. Will there be any off-target things of the gene editing? We don't know. But I think the person who asked this question is thinking very clearly. You should begin to investigate, if you're enrolling in a trial, how much that might impact on your ability to get additional studies and access to them as the world gets new therapies and somewhat complicated. Someone asked, can tafamidis be combined with new drugs that already attack the heart? Yeah, tafamidis can be combined. Like we said before, we don't know if you should combine a stabilizer and a silencer, but it can be combined. We don't know if you should combine a silencer with a so-called extractor or a anti-amyloid therapy. All of that is investigational. Someone asked, what is your opinion on Ionis's 682-884 compound? This is also an excellent silencer. It's if you will, the son of Tegsedi, though it doesn't have much relationship. It's a subcutaneously administered antisense, which also essentially silences TTR like patisiran and vutrisiran. It is administered once every month. It's administered subcutaneously. And there's a very, very large trial, probably the largest that's being conducted, of patients being randomized, 750 people. The one distinguishing feature of this trial, I would say, that's somewhat in its favor is that everyone in this trial is allowed to take tafamidis. And so several of the other trials have caps on the number of patients taking therapy. And so, at least in my practice, I often want to get people on what I know is a therapy that for sure works and they're taking, and then think of something down the road that would be added on top of it. And that study appeals to me in that way. Someone asked, what's the difference between checking troponin I and troponin T? So troponin is a protein that is a part of the heart cells. Your heart has proteins that interact to act as a pulley. There's troponin, there's tropomyosin, they're different proteins. And these pulleys interact in very complex ways. If your heart is being damaged, God forbid, like having a heart attack, you can secrete a lot of troponin, either I or T, into your bloodstream. And that's how troponins are used often in the world of cardiology, God forbid, to diagnose someone at the point of care who has chest pain in an emergency room. Turns out that when you have amyloid in your heart, the amyloid fibrils squish, if you will, and the cardiac cells, and they secrete out a low level of troponin, not enough that's compatible with a heart attack, but enough that often people get confused for that. Troponin I is different than troponin T. Troponin I is usually higher than troponin T, and so patients can get often worried if someone sends them to a local lab, they get a different troponin, they see their troponin jumped. So they can have, an example, a troponin T of 0.05 and a troponin I of 0.05. And so they'll get, 0.025 and 0.05. They think, oh my God, my troponin is double, but that's compatible with kind of the same range. To confound things, there's these regular troponins, and then there's something called high sensitive troponins. And those are being used, just like we say, to really detect small, tiny changes. And those are values that can be 50 or 100. And so I've unfortunately had patients who, when the assays switch over and they see very different values, they get very concerned about these changes. So there's a very important difference. I'm glad someone asked that. Is there any correlation between the amount of exercise, such as a rowing machine, and the effect of stabilization? There's no, that I know of, effect of exercise on the efficacy of therapies. In fact, I would tell you exercise is probably a very important thing for everyone to do, irrespective of what treatment you're getting, and maybe as important or more important than some of the treatments. There's been a suspicion, I just comment on this, by many of us who've diagnosed people with wild type disease, that there may be a relationship between how much exercise one has done earlier in life and whether or not they have this condition. Not that I think exercise causes it. My sense is the following, that people who are very vigorous exercisers, run a lot, several times a week, and marathoners, they recognize small decrements in their capacity to run, and they get picked up more often. And but that's a hypothesis, actually. A colleague, Dan Judge at Hopkins, who's now at Medical University of South Carolina, has always noticed that. Someone asked about, for therapies like silencers that lower the vitamin A, will taking a vitamin A supplement will be effective at maintaining? And the answer is yes. It will maintain normal vitamin A levels, but you have to take it on a daily basis. You have to take 3,000 RDUs of that's recommended daily allowance. You don't want to take too much vitamin A. Sometimes the formulations are 10,000 units, and if you take it at that dose chronically, vitamin A is one of the fat soluble vitamins. A, D, E, and K are fat soluble, and it can build up in the body. but usually about 3,000 recommended daily units. It's usually about the amount that's in a multivitamin. Sometimes there's a conversion factor about the different units in milligrams, and you can look online. Someone here wrote, I'm participating in the AG10 trial. They wrote with tafamidis, added at the 12-month point. My biomarkers seem relatively stable. So I guess this person was taking acoramidis, and then they got tafamidis added at the 12-month time point, which is, I guess, allowed in the trial. Biomarkers seem to remain stable. What is the probability for patisiran or CRISPRs being available? Well, again, you're already in a trial. I would encourage you to stay in the trial, especially if you're doing well and the biomarkers are stable. We don't know what silencers will do or CRISPR. Having said all that, we do hold a lot of hope for those therapies. And if I had to be a betting person, I would bet a lot on silencers or CRISPR-based therapy. In AL amyloid, we know that knocking down the protein and getting a complete response when you eliminate the light chains is better than if you get a very good partial response or even a partial response. So the lower the precursor protein goes, the better. So we hope the same is true for TTR amyloid. That is, knocking down the protein may be as effective or more effective than stabilizing the protein. I don't know how much more time we have, but I can keep going. It seems like there are 50 more questions that keep coming in. Someone else wrote, I lost 15 pounds using diuretic, and now I'm gaining weight back. If you gain weight back slowly, over weeks or months, could be a sign of improvement and muscle, but rapid changes in weight that occur over days or a week are usually a sign of fluid retention. And if you're not sure, I would always encourage you to reach out to your provider and get an exam to check. It's pretty easy to tell the difference. Again, someone asked about post-heart transplant taking tafamidis. Will it slow the neuropathy? We don't know, but if you have a neuropathy, I would strongly encourage people post a heart transplant to think about it. Is there any evidence, someone asked, that tafamidis may slow absorption of amyloid? Well, amyloid's not absorbed, so I'm not sure. There is very little evidence that tafamidis does much to get rid of preformed amyloid. So this person, I think, is asking about, will it help in getting the amyloid out that's already there? And the answer, I think, is no. It's mainly a preventive therapy, and so better when administered earlier before there's a lot of amyloid. Someone asked, how likely it is to have neuropathy with wild type? This is an important question. I don't think anyone knows. Part of the biases are many wild type patients are seen by cardiologists like myself, and I don't have much expertise at evaluating people for neuropathy. The second confounding feature is many people who have TTR are very elderly. Their average age is 75 to 80, and they can have neuropathies for lots of reasons, particularly lumbar spinal stenosis, which may be due to amyloid deposits, but is not directly in the nerves. My colleague here, Tom Brannigan, has been studying such patients. It's certainly not as predominant as a clinical syndrome, that is neuropathy, as it is in variant patients, but it could be there. And as people live longer, it may be an important issue. My husband had carpal tunnel syndrome, and recent blood work showed abnormal kappa lambda right chain. Should he be tested for amyloid? I think he should be evaluated. Most importantly, it would have been nice if the tissue from the carpal tunnel would have been saved and stained for amyloid to see if there was amyloid there. But we often in the amyloid world find people very advanced with amyloid, and so hopefully your husband doesn't have amyloid, but if he does, it would be nice to diagnose him as early as possible because, like I said, the treatments are better. Someone asked, do I have patients on both tafamidis and patisiran? And the short answer is I have less than 5 people on both, and I have hundreds of people I follow. It's very unusual. The therapy is very costly, and they want to know how well it works. And the short answer is I don't know that it works any better. It's not being studied. It's very unusual. Does the clinic accept Canadian patients? Sure. We actually have one of our patients from Canada who's in one of our trials. So we'll take people from anywhere. We have people from Europe and South Africa, all who come. Obviously, COVID's put a crimp on that. Someone asked, why not go to gene editing? I assume why not go right to gene editing? And that may be the case. It may be shown that gene editing is better than tafamidis. And if that's the case, then people will switch over, and but we'll see. We don't know that these therapies need to be added on top. If carpal tunnel and AFib is an indication for wild type TTR, wouldn't all hand surgeons, as a matter of standard practice, be required? Well, required is an interesting word. We don't know what the yield is. Dr. Hanna from the Cleveland Clinic suggested about 10% of people undergoing carpal tunnel surgery who are over the age of, say, 55, especially bilateral, may have amyloid. So is 10 out of 100 enough to require people to do things? If you talk to me, I would say yes. But getting doctors to change their practice and demanding things, that's part of, education and everything else. I do believe that to this person's point, they had carpal tunnel 5 years earlier, had no AFib, and no one made the connection, and they wrote disappointing. And I would agree, it is disappointing. And so I apologize. We all have our work cut out for us. Someone else wrote, anti-CD38 is a pretty blunt instrument. Are there therapies in development targeted only plasma cells that are overexpressing light chains? Not that I know of. There were combination therapies in which CD38 is being combined with, as a delivery mechanism, with a kind of chemotherapy. There's a company, Sorrento, that's doing that for patients with relapsed and remitting AL amyloid. But I am not a basic scientist. But I could envision a way where the CD38 antibody would be used to deliver, ideally, to the right cells. Do all ER doctors know how to respond to a person with amyloid? And the answer is absolutely not. They probably don't know at all how to respond. And that's where we see this issue of people giving a cardizem inappropriately or so forth. So remember, amyloid still is a rare disease. Many doctors have never ever seen a case. That's why I think patients need to be aware, and you need to tell doctors, I have amyloid. Do you know what you're doing? And if they don't look like they have an idea, and they, God forbid, are pretty cavalier, I always tell my patients, call me on my cell phone, right? Don't let them do much before I get there. I've been on Tegsedi or inotersen since 2014. I think that's great. They wrote, but both the heart mass and wall thickness have reduced. That is very encouraging. Do you believe this is a result of natural clearance? Probably not. I think this is the fact that you've lowered the production of the protein, and maybe there is a natural clearance mechanism, but you favored it because of the drug. I'm not sure I understand. They asked something about, do I think that other depositing in the body systematically are also reducing? I hope so. That's the whole idea. We believe if we shut off the precursor protein and stop it using, again, AL amyloid as the model, there are patients who have, God forbid, multi-system amyloid in their kidneys, their liver, their hearts, and we've seen them over the years, their organs get better. So after using Vindamax for many years and maintaining quality of life without major deterioration or stress, should follow-up testing be performed? And the answer is yes. There was actually a recent, I don't know if it's yet published, but in general, most of us advocate that patients should be clinically seen on Vindamax minimally every 6 months. We should talk to them, find out what their symptoms are about. Cardiac biomarkers should be measured in a similar time frame. An echocardiogram once every 1 to 2 years, and some functional measure about how far you can walk, typically the 6-minute hall walk, or a measure of gait speed, or standard things that we're trying to do to follow patients over time. Do standard heart testing, echo and EKG, show early involvement? And the answer is they can if you're attuned to it. The most important is the discordance between you see on the echo, which is the walls are thickening, so they're getting thicker, and the EKG shows that the voltage is getting lower. So if you're a really smart doctor, I always try to teach people this, you can add up all the voltages on all 12 leads of the ECG. Usually every lead is about 10 millivolts. Since there are 12 ECG leads, you can do the math. That is 12 times 10 is 120 millivolts. And usually the normal wall thickness of a heart is 10 millimeters. So it's 120 divided by 10, normal would be 12. That number goes down with amyloid. So if you have a patient who has, a 100 millivolts across all the leads, less than 120, and they have a 20 millimeter wall thickness, you can do the math. That would be 100 divided by 20. That would be a number 5. So it went from 12 to 5. Anything below 8 is very suggestive of amyloid. I saw someone early last week who had pretty good voltage. We did this calculation. His number was about 8. He doesn't have a very thick heart. It's 12 millimeters, 13. We did a PYP scan and we diagnosed him, and he's coming back to see us this week and start on tafamidis. And he doesn't have heart failure. He's pretty early. So it can be used to make the diagnosis, but you have to think about it. Does DARA prevent LC growth and reduce light chains level, or only prevent growth? So daratumumab basically damages or kills plasma cells. It shuts them off. They're the source of the production of the light chain. And so you don't make any more of the monoclonal light chains that you were making. Does the clinic accept, someone asked Canadian patients, second time around, sure. Is the new LICA form of Tegsedi better than the former weekly injectable? Yes, it's, we believe, much better. A, it's delivered once a month. B, it doesn't seem to have many of the side effects related to a platelet count or renal function. Though we're monitoring patients in the study, we believe that it will be a great advance. And they're actually doing a trial right now in neuropathy patients to, I think, try to have it get on the market and replace Tegsedi. What is an acceptable heart rate for TTR patients? And the answer is there's no, I think, standard acceptable heart rate. I mean, I think there are extremes, people whose heart rates are 40, that's probably too slow, and, much below 50, be careful. And people whose heart rates are much above 120, but there's a wide range in between. This person says they're taking ivabradine, which is a interesting drug that we use in patients with systolic heart failure, that is hearts that don't pump well, and has been shown to, it's also called Corlinor. It lowers the heart rate by blocking what's called the IK funny channel in the heart. That's a channel that causes your heart rate, and it does lower the heart rate. I don't know that it's of benefit in people with amyloid, but it's interesting. Someone asked, are you trying SGL2 drugs in cardiac amyloid patients? That's a great question. SGL2 are these sodium and glucose co-transporter drugs that basically have been shown in heart failure with a reduced ejection fraction to be standard of care. And one of the 4 pillars, we're testing them in HF patients, that is heart failure preserved DF, and I think they should be evaluated in amyloid patients. I am not routinely at this point prescribing them, but there are a few patients that we have started them on, but not routinely. Can you prescribe an antibiotic for someone while taking Cyborg D? Yes. You can prescribe an antibiotic. In fact, there's an antibiotic that's sometimes given prophylactically called doxycycline. And Ashu Welker in London was famous for describing that he discovered that that drug might actually have anti-amyloid properties, that is doxycycline. But antibiotics can be given and should be given. Someone else asked about doxycycline in AL patients after a stem cell transplant. And there is some evidence that, these agents, doxycycline might be useful. You have to be careful. It causes a lot of sun sensitivity and can cause some GI upsets. I wouldn't just routinely start it. And I think, I don't know how much time we have. It's already 4:42. Can someone give me advice?
Yeah, we still have about 2 minutes left, 2-3 minutes.
Okay, I'll just keep going. Someone asks, how does one investigate the possibility of a patient being in a silencer trial? I think that's a fantastic question. I think I put that in my talk. But if you're interested in learning about any study that is, under, kind of IRB and approval and is potentially going to impact on patients, it has to be registered on a website that the government runs called clinicaltrials.gov. And if you go to that website and there's a search engine and you type in the word amyloidosis, and you even put in if you had transthyretin, or in this case, someone's mentioning silencer, though some studies might refer to that as knockdown, you can find any study that's ongoing. And it'll say ongoing, fully recruited, not yet started. And if you open up that website, they'll give you details. They'll tell you which company is running it, what's the purpose of the study, how many people they're planning to recruit, is it double blind or single blind, is it randomized, how many people are advocating to each. It'll give you the contact number for the company, so they'll be happy to field your call. And then usually it has beneath that any site anywhere in the world that's doing the study. So if Columbia is doing it and I'm the principal investigator, or my colleague, Dr. Griffin, it'll say our names and the number to call, and you can call our research center. In general, that's the process. You're interested, you want to learn more. It's a pretty big commitment to be in these studies. Many of you who have participated, I'm very grateful. We're all grateful because we wouldn't develop therapies. We want to take good care of people. I think that being in a study is a great thing. In general, I personally believe even if you get placebo, you're better off in a study than not, because you have doctors who are smart, taking care of you and watching things. But you should be, wide-eyed and open about all of this, about what your commitment is, what you're getting involved in, what the risks are. You need to read the consent form. You got to know what the subject burden is, how often you come back. We don't get to decide as doctors doing the study how often the visits are. They're every 3 months, then they're every 3 months. I can't change it. And there are windows that they have to be done on. So, there are some complicating things. People often ask, can I travel? And the answer is, yeah, but you can't travel whenever you want because we have visits that get laid out. So hope that answers. But clinicaltrials.gov is, someone asked about dapagliflozin, which is the SGLT2 antagonist, as a diuretic. It's not a diuretic, but it does because it blocks the absorption of, if you will, sodium and glucose. You pee out a lot of salt and sugar. It can function as a diuretic. And so I think it is a very intriguing idea and something that we've thought of investigating more scientifically. It is, unfortunately, like all these new drugs, nowhere near as expensive as tafamidis, God forbid, but it's not cheap. It's a few $100s a month. And unfortunately, if you don't have an indication that's approved, many insurance companies won't give it to you. So I think the questions about dapagliflozin by this excellent audience only make me want to start to figure out if there's a way to study it a little bit further and give everyone a little bit more evidence. I think that's, I have to say, maybe I'm crazy, but that's all the questions I saw, or they stopped coming in.
Great. Thank you so much. We are at time. So we do apologize if we did not get to address your question. On behalf of Amyloidosis Foundation, I would like to thank you for your participation in today's event. This concludes today's program. Have a great day.